usually I'll take about, for neurosurgery, master of neurosurgery, usually will take about 2 weeks to cover the whole topic. But today I'm trying to condense everything into a 1 hour lecture, or probably less than that, I suppose. Right? So basically what we talk today is on this topic. So basically, is this the, is this the slideshow? This is not a slideshow. Cuma ni. Okay. All right. So basically, this is just the introduction. When we talk about nervous system, basically we talk about a central nervous system, which consisted of brain and the spinal cord. So we'll touch a little bit on the brain and the spinal cord. And also we talk about the peripheral nerve system. Okay, so we talk about peripheral nerve systems. It is further divided into motor and sensory. And under motor, we have the somatic and we have autonomic nervous system, which further divided into symptomatic and also parasymptomatic, right? Sympathetic, all right? On top of that, we talk about peripheral or PNS, peripheral nervous system. They also, because peripheral nervous system also exists in the cranial nerve and actually part of the spinal nerve. Okay, so these are the things that I'll try to cover as much as possible the next few minutes or so. Okay. Now, just to mention, I think this is just a revision. We talked about the brain, the spinal cord. Okay, this is the whole thing about today's talk. Okay, when we talk about nervous system, brain, just as introduction, that at birth, our brain weight is about 400 grams. And as we go older, at the age of 11 to 50 years old, our brain is about 1.4 gram, range between 1.1 to 1.7. The male brain is bigger than the female brain, but it doesn't mean that the male is smarter than the female. Okay, but overall, when we look into the animal kingdom, the relative to body size, a human has got the larger brain than most of other brain. Okay, you can see here, for example, the rhinoceros and the elephant has got a big size body but a small brain. Okay, so we do not want to become like elephant, neither the rhinoceros, where big size but little or small brain. Okay. Now, when we talk about brain, brain can be divided into two parts. One is called as the cerebrum, another one is cerebellum, which is the largest division of the brain. And each cerebrum has got two hemispheres, and each hemisphere has got further divided into 4 lobes, right? So you probably remember in your anatomy class that the brain has got a few layers, or we call as meningeal layers, starting from the deep one, which is the pia mater, and then we got the arachnoid, and the dura mater. Okay, so between the dura and the arachnoid, there is a subdural space, and in the arachnoid, the below arachnoid layer, there is called as a subarachnoid layer. All right, so usually the artery runs in the subarachnoid space. Okay, so subarachnoid space contains CSF and also the artery that runs within that space. Okay. In the context where there is the space is big in the arachnoid space, that is called as a cistern. So cistern is actually part of the subarachnoid space, which is large. Okay. Now, the brain is made. Okay, its development is into folds. Right. So this fold, if this one is called gyrus, or it can be in a sulcus or sulci, grooved. And the big sulcus is called as a fissure, right? So there are few important fissures because these fissures demarcates between the lobes, right? If you can see this picture here, the central sulcus here actually divides the frontal lobe against the parietal lobe, right? So a point which I want to make here is that the brain surface marking is different from the bone surface marking, because for the skull or the bone, the anatomical surface marking for bone that demarcates between the frontal bone versus the parietal bones is the coronal suture, right? So coronal suture will divide between the frontal bone and the parietal bone, and the location of the centers of the coronal suture is way in front from the sulcus sulcus, right? So you cannot assume that if you look at the bone, that any parietal bone, that is your motor stream. No, because the bone surface marking is not the same as the brain surface marking, right? So if you can see the diagram here, that the frontal lobe is the biggest lobe, okay, and then apart from the frontal and the parietal lobes, we do have also the temporal lobe, okay, which bordered or demarcates by the synovial fissure, okay, away from the frontal and the parietal lobes. Of course, the fourth lobe is the occipital, which is mainly exclusively for the responsible for the vision. All right, and so this is the cerebrum, okay, and I'm having a problem. Now, this is just a cross section of a brain. You can see here, it's a very heavy diagram here. You can see here that the brain is, when we talk about cortical and subcortical. So cortical is a gray matter, which consists a lot of, that's where your neurons or nerve cell bodies are located. And the subcortical, okay, or the gray matter, okay, this is where they carries the fibers, right? So this is why in the context, for example, somebody who has got a fracture, for example, penetrating skull fracture. So that fracture can, if this occurs at the brain surface, can becomes the procedure. So that's why in the context of penetrating brain injury, one of the things that you need to pay attention is about the development of seizure, right? So if there's a depressed fracture, impinge on the brain surface, so one of the things that we need to do is actually to do the operation and elevate the fracture, okay? Apart from the gray matter, white matter, or the cortical, subcortical, we do have also what called as gray matter masses. You can see the diagram here. So this is head of caudate. So we have putamen, and also globus pallidus. We make up the lentiform nuclei or nucleus. We also have the thalamus, okay, which is responsible for sensory and also part of the vision tract. Okay, so this is the cross section of the brain. Now, just touch a little bit on the arterial supply. Okay, so basically mainly come from the common carotid artery, which then divides into the external and internal carotid artery. So internal carotid artery will then enter the cranium. The difference between internal carotid artery in the neck level is that in the neck there is no branch in the internal carotid. That means to say, if the branch in the neck, that is actually part of the external carotid. All right. So for surgical, I think both ENT also, you need to know a little about the what do you call, the blood supply, especially the common carotid artery for ENT, important for neck dissection. Similarly with surgeon as well, to understand that the anatomically there is no branch in the internal carotid artery. Okay, because sometimes in the context of extradural, especially those in the basal temporal extradural, in which if you do craniotomy and then you find very difficult to control the bleeding, one of the things that you have to do is actually to dissect the neck and actually to ligate one of the branch from the external carotid artery. Okay, so then to the anterior cerebral artery, middle cerebral artery, which becomes and the posterior cerebral artery, which come from the posterior circulation, which is through the vertebral artery. Okay, so this is another view just to share with you. So you can see here, it's actually part of the posterior circulation, comes from the two vertebral artery, then become one, combine and join to become a basilar artery, and subsequently further divide into the superior cerebral artery and also the posterior cerebral artery. Okay, and then the anterior circulation and the posterior circulation is then communicated to the posterior communicating artery. Okay, so that becomes the whole thing becomes the circle of Willis, right? So that complete the whole circuit. Okay, but of course sometimes there's a variant. This one you don't have to know in detail, but This is specifically for neurosurgeon, but just to share with you that sometimes there is the size of the artery may not be the same, right? From the right and the left. Well, take this for example. You can communicating artery on this side is smaller than the other side. This is called as hypoplastic artery. Okay, whereas the diagram just shows almost the same size, and this one you can see the hypoplastic on the part of the anterior communicating anterior cerebral artery on this side, hypoplastic we call it. So this is the term that we use. If you can see, if you see that the size, one of the artery size is smaller than on the opposite side. Okay. So from the vascular artery supply, this is the cortical vascular territories. You can see here that majority, 2/3 of the hemisphere is actually supplied by the middle cerebral artery or MCA artery. The ACA or anterior cerebral artery supply mainly about 2/3, 2 centimeter away from the midline. So basically, if we look at the motor homunculus, I'm going to show later on, but just to tell you early on, that when we talk about motor homunculus, that the location of the leg control is located more medially as opposed to the hand. So somebody who has got the atrial septal infarct or ACA infarct will have what we call more neurological deficit in the leg as opposed to in the upper limb. Okay, so that's why it's very important for you to understand the cortical vascular territories. That's number one. Number two, sometimes as a neurosurgeon, sometimes medical do refer to you in the context that patient develop MCA infarct, right? So in the context of malignant MCA infarct, where the whole 1/3 of the brain has been infarcted or ischemic, you expect there will be a lot of swelling, which eventually leads to increase in ICP. Then the patient may require decompressive craniectomy. So because 2/3 of the brain is supplied by MCA, okay? It must be malignant, but because MCA has got few branches, anterior, posterior, and the rest. But if the MCA is thrombosed at the trunk, so you expect 2/3 of the brain is gone. But if it's at the branch, maybe only that portion will be involved, but the rest is spared. All right, so you expect the shift will be not much in the context of non-malignant MCA infarct. Okay. So this is a cross section just to share with you. As I mentioned to you, this is the ACA, which is located, or the supply is from about 2 centimeter from the midline. The internal part or the grammasis is supplied by all these different deep branches. Okay, again, this is MCA, so about 1/2 of the brain. MCA also supply, which is inferior division, supply the putamen and also the globus pallidus. So you look at this slide here, because this is the area which is commonly you see a basal ganglia bleed. So I think you probably have seen or heard about basal ganglia bleed. So this is the common area that you will see bleeding secondary to hypertension, right? So we finished with arterial. Now we move on to venous drainage. We talk about venous drainage. There are two systems. One is the superficial and one deep system. All right. So for example, this is the superficial system. The superior sagittal sinus is the superior system, which eventually then communicate into the, we call as a tubular hierophilis, which is the confluence of the sinuses, which then further divide into the right and left transverse, which then drain into the sigmoid sinus, right? So, and then the superior sagittal sinus also communicate with the Sylvian or the Sylvian fissure or Sylvian vein, okay, through this connection, all right? In this case, it's the vein of Trolat. In some area, we call as a vein of Labbé, okay? So these are the superficial draining system. The deep system is like here, you can see here, which is slightly darker in color, which is the called as both internal cerebral vein. All right, so then eventually it will drain into the superficial, it will come up through the transverse to the sigmoid and interjugular vein. Okay, so this is the venous system of the brain. Okay, now move on to the spinal cord. We talk about spinal cord, usually extend from the foramen magnum, which is the hole inside the skull, right, from to L1, L2. Okay, because we know that our spinal cord ends at in adult, it will ends at L1, L2, and generally, because the male is higher than the female, so generally the average size of the length of the spinal cord in male is about 45 and 42 in female. 1 centimeter diameter, weight about 35 gram, and then it transfers to through a bone, through a vertebral canal formed by the spinal column. Okay, and then in terms of development in early fetal, the whole length, and as we grow up in the newborn, lower border L3 and adult is L1, L2, as I mentioned earlier on. Okay, so this is just a picture to show you, right? So that's why it's very important if you're planning for lumbar puncture, you know where you put your needle. Okay, because it's very important, because there are so many things, so many what we call a story about lumbar puncture by the public. Okay, so we do not want to create problem by having a lumbar puncture. Because outside there when I was working in USM, it was very difficult to get a CSF from lumbar puncture because they feel that putting a needle into the spinal space will lead to a paralysis of both legs. They're even willing for us to put the EVD to take CSF rather than putting a small needle inside the spinal canal. Okay, so all right. So very important. When we talk about spinal cord, there are two enlargement: the cervical and lumbar. Obviously, because cervical supplies the upper limb muscles, and for the lumbar, because supplies to the lower limbs. We talk at C3 to T4, and the lumbar at L1 and S3. And then, of course, as it will descend down, the caudally, it will taper down to form a conus medullaris and eventually attach to the coccyx through a filum terminale. Okay, comprises into 31 segments of spinal nerve, has a pair of dorsal and ventral lobes, except for C1. Okay, so very important. There's no dermatums for C1. Okay, and divided into 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccyx. And the first cervical arises from the atlas, and the 8 cervical emerges between the C7 and T1. Okay, right. So this is what it means. So if you look at this is when we talk about spinal segment, this is spinal segment here. You can see that the nerve root, okay, that nerve that comes from that segment go above that vertebral body. So if you have a disc, okay, between C3, C4, there's a disc herniation. So that disc herniation will catch the above nerve root, which is C4. So C3, C4 disc will impinge on the C4 root, right? So because the root is actually go above the corresponding vertebra. Okay. And like the brain, it has got 3 also meningeal layers, pia, arachnoid, and dura mater. But in the spinal cord, the pia mater has got the thinner intima because and the outer layer, epipia. In the spinal cord, the arachnoid is closely adherent to the dura mater, and the space or the space is very narrow and contains CSF and bridging veins. Okay, you just remember in subarachnoid space, that's usually artery usually runs in the subarachnoid space. In the subdural space, usually runs by the vein. Okay, so even in the brain also it runs by the brain. Okay, and blood supply to the spinal cord mainly from 3. One from the anterior spinal artery, the other 2 come from the posterior spinal artery. And at certain level, especially in the thoracic, there is reinforced blood coming from the thoracic, or what called as radicular artery. And this anterior spinal artery arises from the formed by the 2 vertebral artery, and it runs along the ventral or anterior part of the medial fissure and supplies 2/3 of the spinal cord, like MCA in the brain. Okay, so medial spinal artery supply 2/3 of the brain. In the spinal cord, the anterior spinal artery supply 2/3 of the spinal cord. And the 2 posterior spinal artery arise from the small branches of the vertebral artery and also sometimes from the pica, okay, posterior inferior cerebral artery, and supply 1/3 of the spinal cord. Okay, so this is posterior here. This is the ventral, okay, dorsal and ventral. So this is part of the anterior spinal artery, which come from the branch of the vertebral artery, and also the posterior spinal artery, which also comes from the branch of the small vertebral artery. And at certain level, there is a what you call as a radicular artery, okay, that supplies the spinal cord. So imagine if you have anterior spinal artery cut off here, you expect that 2/3, okay, 2/3 of the spinal cord will be missing, okay, will be infarcted. Usually the one aspect will be the dorsal column, because dorsal column mainly is supplied from the posterior spinal arteries, but the rest supplied by the anterior spinal artery. Okay, so this is the whole pictures diagram to illustrate about the distribution of the anterior and the posterior spinal artery. Okay. Now move on to tracks. Okay, when we talk about tracks, there's short tracks and we have a long tracks. So I'm not interested to talk on short tracks. I'm more interested in long tracks. I think this is more pertaining to your area. There are two, when we talk about long tracks, of course, we divide into the sensory tracks. We coin as ascending, yeah, because the sensory is going up to the brain. So it's bringing the signal impulse to the brain. This is why it's ascending, whereas the motor tract is actually descending, sending the impulse from the brain right down to the muscles. Okay, so we talk about that. Okay, yeah, when we talk about sensory, the very important long tract is actually a spinothalamic tract. Okay, it probably which carries a very important modalities, which is for pain and the temperature. Okay, you probably can see the diagram here as the first order neuron comes in to posteriorly to the dorsal ganglion. Okay, and then you have a synapse. Majority, about 80% of the fibers will cross on opposite side and ascending up. Right, only a small percentage of fiber will ascend up ipsilateral. Okay, but the rest will be equisate and cross on opposite side. Okay. All right, so this is a cross section of the spine, just to show you about the structures in the spinal cord. So you can see here, this is the anterior, this is dorsal, this is part of the dorsal column. You got your gracilis and your cuneatus. So this is part of your the tracts and also your what you call your horn. So this is your posterior horn here. Okay, so this is the intermediate zone, and then your posterior anterior, you got intermediate horn, and also you have the funiculus. Okay, the fifth one is the posterior or dorsal, and then you got your lateral, and then you got their anterior funiculus. Each area will carry a different what you call fibers. Okay, so this is your again your ascending tract. You can see here at these different levels, you brings the fibers from one side and cross and equisate opposite side, and then you got the first order neuron, you got intermediate, and then you got the second and the third neuron up here. So eventually your fibers will end up in the sensory area in the brain. Before it reaches that particular area, there will be a station here, which is through the thalamus. Okay, that's why patient who has got a thalamic bleed, depending on the area of the thalamus, will lose some modalities. Okay, say for example, it's a big thalamic bleed, so patient may have a hemisensory loss. All right, okay. So as opposed to dorsal column, the difference between dorsal and the anterior tract or the spinal thalamic is that in the dorsal column, that the fibers will ascend on the same side, the ipsilateral side. It only will decussate on opposite side at the lower part of the medulla, and eventually reach at the thalamus, part of the thalamus, and eventually will reach at the sensory motor cortex. All right, so that's the difference between the sensory spinothalamic versus the dorsal column. Okay, fibers. So these are the tracks. for both motor and sensory. You can see here for the red color is for the motor and the black color is for the sensory. You can see the location very important, because that's why what I want to share with you this afternoon is actually all the long tracks. The small tracks is like, for example, like this one, vestibulospinal, medulloreticulospinal. These are very small tracks. But for your level, I think it's enough for you to understand or to know about the cortical spinal tract, yeah, which in this case is located lateral, so you got lateral cortical spinal tract. Okay, and then we also have anterior cortical spinal tract. Okay, and then the spinal thalamic anterior. If there's anterior, there must be also a lateral spinal thalamic. All right. So imagine if you have what we call hemi-transection of the spinal cord. So you can imagine what kind of modalities will be exhibited by the patient. Okay, very important. Okay. Similarly, if you have infarction involving the anterior spinal artery, so you expect that, say for example, on this side, you expect you will have cut off of blood supply to this tract, and also this one, and also the anterior and spinal thalamic and the what we call lateral spinal thalamic on this side. Okay, this is just to share with you about the arrangement of the fibers. You can see here that for the lateral cortical spinal tract, the location of the arm fibers or the upper limb fibers is located more medially as opposed to the lower limb. Similarly, for the spinal thalamic tract, that the location of the upper limbs is located more medially as opposed to the lower limb. That's why when you take history, for us in neurosurgery, it's very important for you to take a proper history, because most of the time the history will tell you exactly whether the lesion is actually arising from outside or is it from the inside. Okay, so you need to understand the evolution of the symptomatology, so that at the end of the day you will be able to localize where is the lesion. Okay, so I hope you can do the same. Okay, we do not want to train somebody to become like a private surgeon. Everything hantam, tak tahu from brain right down to the toe, semua scan MRI. So we do not want to train this kind of people. Alright, so you need to utilize your brain to understand, to do proper history taking, to do a proper examination, and actually to localize the lesion. Okay, so that's why it's very important for you to know the anatomy. Okay, I know neuroanatomy is a bit boring because there are so many things that you have to remember. But again, if you're going for a full neurological examination, you must understand the neuroanatomy for you, or to allow you to localize the lesion. Right. So in this case, this is the location of the fibers for the posterior, also dorsal column, the cuneatus and the gracilis. So the cuneatus is for the upper limb, it's located more what we call laterally as opposed to the lower limb. Okay. So this diagram is just to show you the dermatomes, right? So you just need to know a few landmarks, the C5, and then the C6 here. Okay, the big thumb there, C6. Okay, and the C7, the middle finger. All right, C8, and then your level of the nipple is T4. Your belly button, T10. Okay, the groin transition between T12, L1. Your kneecap is L3. Okay, the pure L5 is the big toe. Right, the rest is S1, S2, up to S5. Okay, so these are the areas that you need to remember if you're planning to do a proper and full sensory examination. Okay. We finish the sensory, move on to the long tract, motor long tract, which is corticospinal tract. As I mentioned, corticospinal tract is a descending tract from the brain right down to the spine, eventually to the muscles of the upper limb and the lower limb. And also mentioned to you that the location or the homunculus or the location of the motor control for the lower limb is located more midline, okay, medially as opposed to the upper limb. As I mentioned also that the ACA or anterior artery supplies about 2 centimeter from the midline. So imagine from here to here is supplied by the ACA, from here to here is supplied by the middle cerebral artery, right? So looking here knee, so you can first order neuron coming down from the respective area, going through the brain stem, midbrain pons, up to the lower of medulla, where there will be a decusation into the opposite side, to the contralateral side, and eventually descend to the respective area in the spinal cord. All right. So that is the difference between the what do you call the spinal thalamic. So the firing direction is going down to the spinal cord, as opposed to spinal thalamic from the spinal cord going up. Okay. So important points which I want to make here is that if you have a lesion above the medulla before the decusation, so the patient will have a deficit or motor weakness on the contralateral side. So if assume this is on the right side, if the patient develop hemorrhage or infarction or tumor on the right side, then the manifestation will be on the contralateral side. But if the lesion is below or after the decusation, say for example here, right? So at the spinal cord layer level, then what will happen is that the patient will have the deficit on the same side. Okay, that is very important. Okay. So this is what I'm talking about for the last many minutes, just to to show you about the primary motor area and the primary sensory, somatosensory area. Okay, location of the center of command of different part of the body, the legs, the hands, the face, the tongue, and the rest. Okay. Similarly for the somatosensory area. Okay. So move on. We finished the central nervous system. Move on to the peripheral nervous system. I'm going to touch quickly on the cranial nerves. There are 12 cranial nerves altogether, right? Olfactory nerve number 1, which is responsible for smell. Phylogenetically, among the older sensory function. Embryonically is actually part of diencephalon. Okay, you can see here. This is part of the bone. Okay, this is already inside the brain. All right, so this part in the nasal. Okay, you can see all this different kind of neurons, the granule cells, mitral cells, or the receptors which are located in the nasal part. Okay, and you can imagine that there's a transmission or signaling from the nasal up to the part of the optic tract into the part of the brain to be processed. Right, optic nerve, which is responsible for the vision and for the pupillary light reflex, which is also a special sensory afferent. Congenitally, it's not a true peripheral nerve, but it's actually a tract of the encephalon, like the olfactory nerve as well. Okay, responsible for the vision. So this is the visual pathways. Okay, you got from the eye, the retina, the optic nerve, the chiasm here. Okay, for ENT, sometimes patients with pituitary tumor, they will confess on the chiasm. Then therefore, they will, one of the symptoms that the patient will present is due to the bitemporal hemianopia. Right? So patient cannot see all the peripheral vision. And then subsequently, after the optic chiasm, we have the optic tract. Okay, and then will transit for a while in the lateral geniculate body, and eventually becomes the optic radiation and end up in the primary cortex visual area, which is in the occipital. Okay, so this is the visual pathways, and of course, for the visual reflex, from here it will go to the lateral geniculate body and eventually go to the part of the brainstem, which is at the level of the midbrain, and it will return the impulse back to the iris, which is then eventually you will see upon giving the light, the pupil will constrict. So this is part of the light pathway, but the rest of the visual processing will end up in the occipital lobe, which is the primary visual cortex. Okay. So this is the primary visual cortex at the occipital. If you have injury here, for example, So patient will have a cortical blindness, right? So even though the eyes is intact, the rest of the optic pathway is intact, but if there's a lesion at the cortex of the primary visual cortex, you will have a cortical blindness. Okay. And then we were now is actually oculomotor nerve. There are three important nerves or cranial nerve that is responsible for eye movement. 3, 4, and 6. Basically, 3 and 4, the nucleus is located in the midbrain, and 6 is located in the pons. You can see a very complex diagram here, right? So the oculomotor is very important also, actually part of the visual pathway. This is the tactus or tactile nuclei that was telling you just now, which is very important for light reflex. So this is part of the red nucleus. So this is part of substantia nigra, which is part very important, and also part of the what I call this area called as a crus. That's where your cortical spinal tract will run through as it descends down into the spinal cord. Okay, so it's all pair except for the levator subnucleus, which is located right in the middle. This levator subnucleus is important for the what they call elevation of the eyelids. Okay, so if you have a lesion here, so you have a problem with, you will manifest as a ptosis. Okay, so that for the levator pulpobri is supplied by a single nucleus, which is located in the midline. All right, but the rest has got the pair, right side and the left side. Okay. Okay, this is the oculomotor, the trajectory from the midbrain. Okay, and then will extend or move forward and eventually end up in the cavernous sinus. Okay, so as you move along, it's very close by to the posterior communicating artery. That is why if somebody present with sudden onset of ptosis, one of the differential diagnosis is the posterior communicating artery, because the oculomotor just sitting below the PCOM, right? The fourth nerve, which is trochlear nerve, okay, which is the only nerve that rises from the dorsal part of the brain. The rest come straight anteriorly. You can see here it's actually cross. So that cross. So on the right will cross toward the left contour toward the right. So it's actually a cross nerve that supply a contralateral superior oblique muscles. If you remember SO4 LR6, okay, so pre-oblique supplied by the trochlear nerve, lateral rectus is supplied by the sixth nerve. Okay. Okay, this is the trochlear nerve, which is the sixth nerve, which is the longest nerve. Okay, come. Sorry, trochlear. Sorry, this is fourth nerve, trochlear nerve. Okay, supplied to the superior oblique nerve, superior oblique muscles. Okay, this is abduction, which is the sixth nerve. All right, supplying the lateral rectus. Okay. So all the third, fourth, and the sixth nerve will end up in the cavernous sinus, and then will go to the superior oblique fissure to enter and supply or innervates the muscles of the eye. Okay. Okay, as I mentioned you, this is part of the cavernous. You can see the location of the third nerve. Okay, the fourth nerve and the sixth nerve. Right, so it's all located in the lateral wall of the cavernous sinus. Okay, so in the context of, say, for example, a cavernous meningioma, so all this nerve, third, fourth, and the sixth, including the trigeminal, part of the trigeminal, which is the ophthalmic, and also the maxilla will also be involved if there's a lesion in the cavernous portion. Okay. The trigeminal nerve is the largest. It carries both sensory and motor modalities. Okay, as I mentioned to you, ophthalmic nerve. Okay, which actually the fifth nerve also arises from the pons. You will end up in the lateral wall of the cavernous sinus and will exit to enter the orbit through the superior orbital fissure. and it has got all these branches, the lacrimal, frontal, and also ciliary branches. Okay, the second big branches is medullary nerve. So it will cross through the cavernous sinus from the brainstem, from the pons, enter the lateral wall of the cavernous sinus. That instead it will go through the superior orbital fissure. It runs into the foramen of right tandem, which is part of the in the base of the skull. Okay, so there are few foramen in the skull that you have to remember. One is the foramen, the ROS, rotundum, ovale, and spinosum. So rotundum carries the what we call the maxillary nerve, okay, and the rotundum, so ovale, ROS, ovale will carries the medullary part of the trigeminal, and spinosum will carries middle meningeal artery. All right. So if I ask you in the what we call in the MCQs, what are the nerve or what are the arteries that pass through this foramen? So these are the answer. Okay, bagi clue ni. Okay, so the mandibular, okay, it goes into the ovale, right? So this is the sensory distribution of the what we call trigeminal. So the ophthalmic artery, the maxilla, and the mandibular, right? So if you want to do your pain and temperature, this is the area that you need to touch in order for you to find out whether the deficit come from either any of the three branches here. The facial nerve carries both motor, sensory, and also part of the autonomic fibers. Sensory is responsible for the two-thirds of the tongue, which is responsible for taste. Motor is responsible for the muscle of facial expression. Autonomic carries are responsible for the lacrimation and salivation. Okay. So for ENT kena tengok ni, you have to understand this because these are the what we call the pathway of the seven nerve. Okay, in the context of trauma, sometimes you may have what we call a fracture of the mastoid F cells. You would expect if it is mastoid F cells. So these are the areas that can be affected. Okay. So lesion in the CP angle, say for example in the context of a short CP angle, so you expect this area that will be affected. Okay, so in the pons. All right. So I'm not going to go through details. As I say, for seven nerve usually would take about 1-2 days to finish. Okay, so almost impossible to discuss with you in 1 hour's time. Okay, now it's not moving. Okay. Vestibular cochlea, very important for hearing and balancing. It has got two portions, the cochlea and the vestibular. Okay, cochlea is for the sensory for hearing and vestibular for balancing the equilibrium. You can see that in the point which I want to make here is that the processing of hearing eventually end up in the part of the midbrain, which is the inferior colliculus. Okay, if you look at the midbrain has got 4 colliculus, 2 in the superior, we call as a superior colliculi, 2 in the inferior colliculi. So superior colliculi or colliculus is actually responsible for light reflex at the level of oculomotor. Just now I was telling you, okay, in the pre-tecta nucleus, which is located in the superior colliculus or colliculi, that's responsible for the light reflex. But for the inferior colliculi or colliculus, that's where the processing for the hearing before it reach the temporal lobe, okay, which is the processing for the hearing. Okay, so these are the two level. So up to the temporal is, so it's starting from the hair in the ear up to the level of the temporal region, and then transit for a while in the inferior part of the brainstem. Okay. So this is vestibular portion, which is responsible or very important for balancing. So they are the semicircular canal. Okay. And then the glossopharyngeal, which is responsible for swallowing. Okay, so it has got all this nucleus ambiguous, inferior, which carries the parasympathetic, and nucleus solitarius, which is responsible for the sensory. Okay, the vagus. Okay, so the touching or sensation is the 9th. The barking or the gagging is by the vagus nerve. Vagus nerve also carries both motor, sensory, and also the parasympathetic. All right. So they both exit the skull through the jugular foramen to enter the carotid space in the along the carotid artery. Yeah? So very important if you dissect in the neck for the surgeon and also for ENT to know the content of the carotid sheath. Right? Because it came up, I think 5 or 6 years, it was my question asking about written on the short notes on the carotid sheath. Right? So one of the structures is a nerve, which is a vagus nerve. Right? There you are, vagus nerve. Okay, accessory nerve, nerve number 11. Okay, which is origin for again nucleus ambiguous, and also supply to the upper part of the spinal cord, responsible for the motor movement of the trapezius and also the sternocleidomastoid muscles. Hypoglossal nerve, which is the 12th nerve, responsible for your thumb movements, is a paramedian location along the posterior cerebral artery, located anterior or ventral to the fourth ventricles. You can see here. All right, and then responsible for the thumb movements. Okay, so function is actually a pure motor. It innervates both the intrinsic and extrinsic muscles of the tongue. Okay, of course, the intrinsic has got the longitudinal vertical transverse, and extrinsic has got the following muscles. Okay, and spinal nerve. Okay. Okay, sekejap You just take a 1 minute break. Para pesakit dan pelawat sekalian, waktu solat zuhur akan masuk dalam tempoh 15 minit daripada sekarang. Marilah kita bersama-sama menunaikan solat di awal waktu, kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, solat di awal waktunya. Adalah dimaklumkan bahawa susulan perintah kawalan pergerakan diperketatkan PKPD di 7 mukim daerah Kuantan. Solat fardu boleh dilaksanakan di tempat masing-masing mengikut SOP yang telah ditetapkan. Tiada solat berjemaah dilaksanakan di musalla kecuali beberapa orang yang bertugas sahaja. Sekian, terima kasih. Okay, spinal nerve coming up from the spinal cord. Basically, these are, if you roots, trunk, ramai. Okay, this is anterior. This is the ventral, and this is dorsal. This is the ganglion, the root ganglion, which carries the sensory. Eventually, you come up through here. Okay, some of the fiber go on opposite side to ascend up to in the primary sensory cortex. Okay, and then things which I have to remember, or things that you have to remember on, is actually a brachial plexus and the lumbar plexus here. Okay, as I mentioned just now, root, trunks, division, and cords. That's where you got all the nerve coming from this area. Okay, so similarly for the lumbar plex, I'm not going to go into detail. This is for your homework, for you to go through. Okay. So the last bit for today is on the autonomic system. This diagram just to show you about the somatic motor neurons coming from the anterior horn of the spinal cord into the effector here, which is the muscles. And for the autonomic motor system, the difference between the somatic and autonomic is that in the system, it has got the preganglionic, because there's an autonomic ganglion outside the spinal cord. Okay, you got the preganglionic neurons, mostly are myelinated, and you got postganglionic neurons which are unmyelinated. Of course, I mentioned earlier on in my slide, autonomic motor neuron can be divided into the sympathetic and parasympathetic. Okay, you can see diagram here. Okay, this is just a chain of the sympathetic outside the spinal cord. Parasympathetic, you can see here that the better diagram. Okay. The parasympathetic here, he has got a long preganglionic sympathetic, which has got a what you call a shorter preganglionic. Okay, this is the parasympathetic. You can see the preganglionic neurons is shorter as opposed to the parasympathetic. Okay, which has got the longer preganglionic. But a shorter postganglionic ganglion. Okay, so in this context, the parasympathetic location of control is located in the S2, S4 region, and some of the parasympathetic system also existed in the cranial nerves, as I already mentioned in the cranial nerve. Two different systems. Okay, saya rasa itu saja which I like to share with you. I'm not sure whether they allow you to have any question, but I will back to you to the chairperson. Hello.
Yeah, thank you, Prof. Selfie.
Is there
We only left 1 minute. We can actually accommodate one question. Any question from the floor?
Sorry, I have to rush through because I think it's very difficult to condense the whole 2 weeks lecture into 1 hour.
Yeah, actually, Prof, we actually can accommodate another 5 minutes because actually it's our lunch break now.
Because but whatever questions that I'm going to ask, either in the form of essay or in the form of MCQ, will be based solely on my presentation, because it's not fair for me to ask anything beyond this. You're not going to be a neurosurgeon. I think what I presented today is actually enough to cater you as a general surgeon and also for ENT surgeon, because I already put some enforcement, like ENT surgeon, they need to know about the seven nerve or the cochlear nerve. I think the parasympathetic, sympathetic, I think the general surgeon needs to know as well, because they involve the controlling of the bowel, of the bladder, and also when involved the section of the neck in the case of thyroid, similarly for ENT. Okay. So ada soalan ke?
Yeah, there's one question from the floor.
Doctor, I want to ask regarding decorticate rigidity and decerebrate rigidity. What is the difference between both and the track? Decorticate rigidity and decerebrate rigidity.
Now the thing is, when the decorticate and decerebrate means or imply different things or different prognosis. Somebody who has got a decerebrate posture has got a poor prognosis as opposed to somebody who has got decorticate posture. So kalau kita imply into GCS, those who are in the what we call a motor of 2 is considered as decerebrate. Those who are in motor of 3 is considered as decorticate, because it manifests that somebody who has got a decerebrate posture means that the pathology has already involved the brainstem. Somebody who has got decorticate posture is only involved the cortical, but the sparing of the brainstem, right? So that manifestation involved because involvement of the corticospinal tract. Okay, faham? So maksudnya when you do a GCS charting, you find that the patient motor power or the M component of the GCS is 2, that indicate decerebrate posture because they are already extension to pain. Okay, somebody who has got or manifest a motor score of 3, that indicates of decorticate posture, meaning to say that it's better than the decerebrate posture. Ada lagi yang tertinggal ke? Do I answer your question?
Yeah. He said
So
yes.
basically involve the what do you call the cortical spinal tract lah. Cumanya involvement satu already involve the brainstem level, satu lagi not yet brainstem. So that's why somebody who has got a motor power of score of 3, then you have quickly to bring to the OT lah if it's operable. Then you can save the patient. But somebody who is already decerebrate posture, then the process is very guarded lah. So you have to think twice whether you should bring to the OT or not lah, because already evolve impinging or compressing the brainstem. Okay.
Any other question from the floor?
So, okay, I think there's no question. Thank you very much for listening. I hope you have learned something this afternoon.
Yeah. Thank you. Thank you.
More than happy. If you've got any question, you can always come to where I am. So you can always come to my room and definitely you can ask any questions. All right, with that, thank you very much. Back to you.
Thank you.
Thank
Thank you. Yeah. So